Let's begin our program. Welcome everyone, and thank you for joining today's webcast, where we'll discuss the just released report, Oral Health in America, Advances and Challenges. One housekeeping item before we begin, please be aware that all participants will be in listen-only mode throughout the webcast. Although Zoom allows you to raise your hand in this format, we will not be calling on people. Also, this webcast is being recorded. Lastly, if you are in need of closed captioning, that option is available if you mouse over the Zoom window on the bottom of your screen. Now, I have the pleasure of introducing our speakers. Dr. Rena D'Souza is the director of NIDCR, which led the drafting of the report. Dr. D'Souza will provide some prepared remarks, followed by prepared statements from co-project directors, Dr. Bruce Dye and Dr. Judith Albino. Rena, we'll start with you.
Thank you for the introduction, JD, and welcome everyone. Really appreciate you joining us as we herald the release of this much awaited, anticipated report. Here's my little toast. I would like to take a minute to introduce the other person you see on your screens, Dr. Renee Joskow, who recently joined NIDCR. I have asked Renee to come aboard as my senior advisor, as she will serve as the Institute's spokesperson with regard to the report going forward and the subject matter expert, as her credentials are really well suited for that role. So Renee, might you share a brief biographical sketch of yourself?
Thank you, Rena. Good afternoon. Well, let's see. I'm a dentist and a medical epidemiologist, and I have a DDS and a Master's of Public Health degrees from Columbia University. I then completed a hospital-based general practice residency and later a dental public health fellowship. I was in academia and private practice for about half of my career. But immediately prior to coming to NIDCR, I served 10 years as the Chief Dental Officer of HRSA, a sister agency in the U.S. Department of Health and Human Services. I've also held positions at the Centers for Disease Control and Prevention as an EIS officer or Epidemic Intelligence Service. I've worked in the Office of the Surgeon General, the Department of Homeland Security, and the National Institutes of Health National Center for Advancing Translational Sciences. I am thrilled to have the opportunity to apply my experience, my expertise, and my enthusiasm to this very important project. Thank you so very much, Rena, for welcoming me to NIDCR.
So happy you're on board, Renee. Thank you. Well, as you all know, this 2021 report is a follow-up to the seminal report on our nation's oral health that Surgeon General David Satcher released 2 decades ago. That original report, which was considered a milestone in public health, firmly established oral health as being intrinsically linked to overall health and well-being. It also highlighted the striking disparities and inequities among Americans related to disease burden and access to affordable healthcare, oral healthcare. In 2017, Dr. Satcher and Dr. Joyce Nottingham published a partial progress report in the American Journal of Public Health. While our scientific understanding of oral diseases has continued to expand, they said oral health disparities still too often contributed to the prevalence of oral disease in America. That message continues to ring true, and it is a cornerstone of the report we have released today. Drawing on information from public research and evidence-based practices, the report provides a comprehensive picture of the state of oral health in America. While progress has been made in some areas over the last 20 years, much work remains. The report is intended as a roadmap for the way forward. This call to action is only made more urgent by the global COVID-19 pandemic, which has so starkly demonstrated the mouth's role as the gateway to the rest of the body, and that the people and communities most affected by the pandemic are the ones who are in fact most in need of oral health care. The report details ongoing research into the role of the oral cavity in SARS-CoV-2 transmission and infection. So research, innovation, and new technologies are essential to guide us through this and future public health crises is absolutely critical. The report also shows that despite the importance of oral health to overall health and well-being, oral health care is not equally available to all Americans. Key to addressing such disparities is to understand how differently people experience oral health in this country. The report details how age, economic status, and social and behavioral determinants play into these differences. This is a realization that I feel has grown over the last 20 years. Very good to report that. These data serve as the foundation for specific recommendations on ways to improve oral health for all Americans. While the path ahead is daunting, I'm optimistic that we, the oral health community, are more than ready for the challenge. I thank you for all your dedication to this critical endeavor. And it's a great pleasure for me, with a heart filled with gratitude, to turn this over to Bruce and Judith, who will share some additional insights from Oral Health in America. Bruce?
Thank you, Rena. This report presents oral health as an integral part of our lifespan, influencing our general health and well-being from conception to our last remaining years. It reminds us of how the environment we are born into, experience as children, and grow into adults affects the quality of our oral health. As Rena mentioned, this new report reinforces those earlier conclusions regarding the connection between oral health and overall health. For example, today, there are at least 57 systemic health conditions associated with periodontal disease alone. It also reminds us that good oral health remains out of reach for many, even in the presence of the most technologically advanced dental care delivery system in the world. This report outlines the many challenges facing the oral health workforce today, how dental practice is evolving, the forces affecting our existing dental educational models, and integration of oral health care and primary care. And to echo again something Rena mentioned, this document chronicles the persistent, difficult problem we continue to face as a nation, improving access to dental care. In the last 2 dental decades, we've made notable progress in extending nearly universal coverage to children, but about half of the older adult population remains uncovered today. This is a challenge that needs to be addressed. Our country is aging at a faster rate than ever before. In less than 15 years from now, there will be more people aged 65 and older living in the United States than there are youths under the age of 18 for the first time. Inadequate access to care is not just a problem for the United States, but a global one as well. Efforts are now underway to address the lack of dental coverage at the global level, starting with the World Health Organization's 2021 World Health Assembly resolution calling for a global oral health strategy. Over the course of the next couple of years, an action plan should emerge that includes a framework to monitor development of universal health coverage. We've now have seen how promoting access to care and expanding the universal dental coverage can help lower the prevalence of untreated oral diseases at a population level. For example, this report highlights several federal, state, and professional and other NGO initiatives implemented since the 2000 report that focused on improving access to dental care for kids, especially our young children. As a result, we've seen the prevalence of untreated dental caries in preschoolers decrease from about 19% to 10% in the United States in less than 2 decades, a remarkable decline that has not been seen over the course of the last 50 years. Over the many topics this report covers, one of the most important is how pain, mental illness, and substance use disorders and oral health interact. For the first time, we've aggregated what we know about these issues and the associated challenges and limitations to solving them, while also providing some hope for the directions we might be able to go, both to improve oral health for those affected and to help oral health providers navigate a world that is quite unfamiliar to them. Along those lines, it also highlights the significant challenges surrounding the opioid epidemic, including important changes in dental providers' prescribing practices. 2 decades ago, dental providers accounted for about 1 in 6 of the immediate release opioid prescriptions written. Today, dentists now account for about 1 in 15 of those IR released opioid prescriptions. Although this is good news, preventing and managing oral pain remains a challenge. For example, opioid prescriptions remain high when a patient seeks care in emergency rooms for dental pain. As healthcare providers, we're also reminded by this document why integration shouldn't stop when primary care providers deliver fluoride varnish or help their patients find dental providers for care, nor when dental providers offer glucose screenings or even vaccinations. Integration is also about having important health information available at the point of care, and why an integrated electronic health record is important for advancing health outcomes for individuals and for populations. The future of patient-centered care depends on the integrated electronic health record. An integrated electronic health record also will advance research opportunities ranging from clinical informatics to public health. Finally, oral health in America reflects the oral health knowledge base today. We are extremely grateful to everyone who has participated on this project, and now we need the broad oral health community to translate this knowledge into action, improving the future of oral health for all. The most important story to take away from this report is that good oral health for all is within reach.
Thank you, Bruce. As Rena mentioned in opening, this is the first major report on oral health since the 2000 Surgeon General's report. And it is important to view this report from the perspective of where we were 20 years ago. There's been great progress in many of the areas where changes were recommended, yet many challenges persist. But these ongoing challenges do not represent failure. The progress in science and technology during these years has been astounding, and these advances are changing both dental treatment and our approaches to the prevention of disease. New knowledge of the oral microbiome and discoveries in genomics are revealing relationships among systemic diseases that will change what is possible for the future of oral health. But at the same time we have seen these advances, we have seen our goal of oral health for all take new forms and new meaning. The population of this country has changed, and the shape of society is constantly in flux. But the overwhelming bottom line is that inequities persist. They persist for some of the same groups, and they are affecting new groups as well. We have become increasingly aware of the social determinants that contribute to these inequities, and we are just beginning to understand how to use that information to develop strategies for promoting oral health and preventing disease for all groups. In a changing society, expectations are shifting for healthcare delivery as well. As Bruce touched on, we see new models taking shape in which other health professionals take some responsibility for oral health, and dental professionals assume some new roles as members of a broader healthcare team. These changes are being facilitated by enhanced electronic health records that will integrate oral health with other aspects of our health. Who provides oral health care, where they provide it, and what that care looks like will change in the coming years. The emergence of mid-level providers and other new types of healthcare personnel is occurring just in time to address the new groups who are underserved, including the growing class of aging citizens, new immigrant populations, people with substance use disorders, and those with mental health or other special health care needs, to name just a few. It is our hope that the information gathered for this report will provide a catalyst for changes beyond what we can currently imagine. As Bruce indicated, the education of dental professionals will need to include new understandings of the etiology of disease and its prevention. Our public health sector will need to find new ways of addressing the needs of a changing population. And the innovative solutions highlighted in this report will provide a starting point for these and other changes. Finally, I would surely be remiss in not mentioning, as Rena did, the new knowledge about COVID-19 and its impact that is growing even as we speak. This pandemic did not just disrupt the progress of this report. It disrupted our thinking about infection control related to oral health, and it will change forever the way that dental treatment is delivered. It also highlights one of the major themes of this report and perhaps has brought that theme to public attention in ways that we could not otherwise have done. The lessons we have learned about who will suffer are the same, whether we are talking about COVID or caries. It will be those who don't have the same access to information and to care, those who by virtue of their race, ethnicity, age, financial resources, comorbidities, or living environments cannot access care. And it is each of these groups and the individuals within them whom this report tells us we must not forget. The benefits of oral health will be ours as a nation only when those benefits are available to each and every one of us. The primary message of this report, then, for the dental profession, for education, for public health, and for research, is that our many and diverse efforts must converge on the path that will lead us to oral health for all.
Thank you, Judith. At this time, I'm going to ask our panelists to answer just a few questions we took in advance from some of our stakeholders. The first question is for Dr. Dye. Following the publication of the 2000 Surgeon General Report on Oral Health, a national call to action to promote oral health, a public-private partnership under the leadership of the Office of the Surgeon General was published. Will the new report include a separate call to action to provide implementation strategies, or has this information been integrated into the main work?
Thank you, JD.
Bruce?
Thank you, JD. It will not include a separate call to action similar to what was provided in 2003, following the 2000 release of the Surgeon General's report. However, we have embedded within the current report several call to action statements that are directly relevant to each section of the major topic area covered, as well as a set of 3 overarching call to action items that will reflect the report's major findings.
Great, thank you, Bruce. Our next question will be for Dr. Albino. Will the report be making any new or stronger recommendations for improving linkages between oral health and primary care as a way to mitigate complications from chronic diseases such as diabetes, hypertension, and cardiovascular disease that are directly related to poor oral health and or lack of access to oral health care services? And the second part, if so, what are they and how can we incentivize adoption and or implementation?
Well, the report is not making specific new recommendations regarding the management of oral diseases or mitigation of complications from chronic diseases. However, the report is highlighting the exponential growth in new information gained over the last 20 years in the area of oral health and systemic health. For example, the report points out, and I think Bruce mentioned this earlier, that periodontal disease alone has been shown to be associated with more than 50 systemic health conditions. And while association can never be construed as causation, we must not dismiss this information either. It is clearer today than 20 years ago that oral health is integral to overall health, but we still have so much to learn about the underlying connections before evidence-based recommendations can be provided.
Great, thank you, Dr. Albino. Next question, Dr. Dye. What does this report say about the need to increase access to oral health services for high risk and vulnerable populations as part of an overall strategy to improve health equity within health systems and within state health departments that work with vulnerable populations and communities. And furthermore, what are the primary policy levers that need to be pulled to make that happen?
Well, JD, I think the report's conclusion is very clear about access to care. It has remained the greatest challenge for the United States since the release of the 2000 Surgeon General's report. We've had a very disjointed approach to improving dental coverage in this country over the last 20 years. Although that approach has benefited young children, it has not benefited all. On the success side, we have universal dental coverage for children, but on the other end of the age spectrum, we barely have half of the older adults having some form of dental coverage. One of the better approaches to help with reducing oral health inequities, certainly to prevent those inequities from increasing, is to expand affordable dental coverage. As I mentioned earlier, on the global level, expanding dental coverage to a point where countries have some form of universal health coverage is a priority for the World Health Organization and represents an important activity at the global level and is part of the developing global oral health strategy as an equitable approach to reduce oral health disparities and improve oral health for all.
Great, thank you, Bruce. Dr. Albino, anything to add to that?
Thanks, JD. Well, I think I would just reiterate that the report points to improving access to care as a critically important strategy for improving health equity. One of the report's three main calls to action, in fact, states to significantly improve the nation's oral health, policy changes are needed at all levels to reduce or eliminate social, economic, and other systemic inequities that affect oral health behaviors and access to care. Many of these policy changes can be enacted at the state level, and these actions will need to be developed and implemented, focusing on individual state needs. This is an area where state and local oral health leaders and champions and other stakeholders can work collaboratively to advance oral health for their vulnerable populations and communities. Rena, I'll turn this back to you.
Thank you both for those very well-balanced answers. And of course, we'll keep the conversation going. I want to take this chance now again to thank you both for your tremendous work that made this report possible. I'd like to thank NIH and HHS leaders who supported the efforts, including Surgeon General Jerome Adams, the current Surgeon General Vivek Murthy, Dr. Francis Collins, former director of NIH, and Dr. Larry Tabak, one of our own, the acting director of NIH, who made many things possible. And please know there were many more people to thank. In fact, over 350 people contributed to the writing of the report. These contributions were curated by a team of 26 editors who were led by our two senior editors. The report has been reviewed by over 70 peer reviewers, 9 senior reviewers, and dozens of other reviewers participating in the federal review process. Through public comment, we had nearly 200 submissions describing innovative programs and approaches that are addressing oral health challenges. Today is just the announcement phase of the report, but tomorrow and in the days and months to come, we will turn this attention to action and look to use the information in this report to strategically fulfill NIDCR's mission going forward. We will soon release our 21-26 strategic plan. I encourage all of you to check our website next month to view this plan and any updates we have to the report's landing page, which JD will provide. The Lancet just released their a comment on the report right about now. So that's another resource to read through. I want to end wishing you all a wonderful and safe holiday season. Be well, stay in touch, and thank you very much for your interest in NIDCR and for your support of oral health.
Thank you, Rena. Just to let folks know, we did tweet to that Lancet perspective piece this afternoon. So if you visit us on Twitter, you can access that particular perspective piece there. This concludes our call for today. Some of you asked if we will be putting out a toolkit, As shareable resources become available, as Rena mentioned, we will put them on our landing page for the report. The report can be found at www.nidcr.nih.gov/oral health in America. If you have any questions about the report, please email us at oralhealthreport@mail.nih.gov. We thank you, and this concludes today's webcast.
Thank you, everyone.